questions that will help you to understand how to attempt questions in the NEET exam. And this last leap sessions should give you some idea about the kind of questions and how you should attempt these questions. So let's start with the first question. This is a question of a patient who is coming with hepatitis. He's an IV drug abuser. He's got history of IV drug abuse with abnormal liver function tests. He denies any high risk exposure for over 6 months. A viral hepatitis screen reveals the following. His surface antigen is positive and his hepatitis B core antigen IgG is positive and his hepatitis C antibody is positive. You do realize that these antibodies do not have any protective role. Okay, the ones that are there in the, except for antibodies against surface antigen, these antibodies, the presence of them actually indicates that the patient has got infection, especially the hepatitis C antibody. When it is present, it could be that the patient has got hepatitis C infection inside. So they're asking what appropriate results do you get from this serological results? How do you interpret this? Now, in this kind of questions, some simple concepts, let's just run through them. So in patients with acute hepatitis B and chronic hepatitis B, they do ask questions on serological markers in our exam. So if you look at surface antigen positive, along with surface antigen positive, it depends what the MCQ is giving. If they give you IgM anti-HBsAg is positive, the combination of this suggests the patient has got acute hepatitis B. Okay, if the patient has got surface antigen positive and he's also got IgM anti-HBsAg positive, then this is, as you know, core antigen never comes out in the blood. It's antibody against core antigen that is there. And if that is IgM, then you know that this is nothing but acute hepatitis B. However, if the patient has got IgG anti-HBsAg, then we're going to say that this patient has got chronic hepatitis B. The important point to remember is that for chronic hepatitis B, the essential rule is surface antigen must and should be present. Okay, surface antigen should be present for you to make the diagnosis of chronic hepatitis B. So surface antigen is positive, IgG anti-HBsAg is there. That means this patient has got chronic hepatitis B. However, if the MCQ gives you antibody against surface antigen, and let's say the patient has got IgG anti-HBsAg, this combination suggests that the patient has recovered from hepatitis B. You should know that when the patient has got vertical transfer, that is from the infection being picked up from the mother transplacental route, so around pregnancy, if the infection is picked up by the baby, then this likelihood of the baby developing chronic hepatitis B is very, very high, almost to the tune of more than 90% chance that the baby is going to develop chronic hepatitis B. However, as you know, hepatitis B can come through two main routes. One is vertical, the other is horizontal. Horizontal route we talk about as transsexual. It is IV drug abuser. It is needle stick injury. It is blood transfusions. All these are basically horizontal transfer. Any horizontal transfer, the risk of it converting to chronicity is only about 1 to 2%. So the risk, it could go up to 5%, however, but the risk is very, very minimal compared to what you saw in vertical transfer. Meaning a significant number of people do pick up the surface, the infection. They will develop something like acute hepatitis B and they'll recover. And once they recover, what you see in the blood is going to be antibodies against surface antigen and IgG anti-HBsAg, meaning the patient is recovered from the problem. He right now does not have chronic hepatitis B. This patient has recovered. As I told you, if the person gets the infection via needle stick injury, or if the patient has got through blood transfusion or transsexual route, or if it is coming through the IV drug abuser, whatever, the chances of the person recovering and going to, the risk of going to chronicity will become very, very less. Single exposure I'm talking about. Once you are having a patient having anti-HCV, then you should know that this antibody does not have any protective role. It indicates that the patient has got hepatitis C infection. Obviously, the next step in management is we are going to confirm further by doing the HCV RNA levels. But once you get anti-HCV in the MCQ, you should consider the possibility that this patient has got chronic hepatitis C. Okay, chronic hepatitis C. As you know, the acute hepatitis C is so transient that it is not going to be picked up. Most of the patients are asymptomatic during acute hep C. And this is the reason why majority of the times when you diagnose hepatitis C, it's generally in the chronic form. In this question, what we are noticing is you see the patient has got surface antigen positive. Both the antibody against surface antigen is negative. The IgM is negative, telling you that this is not acute hepatitis B. the patient has got IgG positive. The combination of this and this I told you is going to indicate that the patient has got chronic hepatitis B, right? This is nothing but chronic hepatitis B. Now, once you say this chronic hepatitis B, apart from that, what you're also getting is a patient having anti-HCV antibodies present. Once that is positive, the patient has also got chronic hepatitis C. So that's your conclusion. The patient has got a combination of chronic hepatitis B and chronic hepatitis C. And the option in this, you can see this is nothing but chronic hep B and chronic hep C infection. So these kind of questions, they should be very easy. Serological questions generally are asked in an exam. Carefully look at this concept. When they give you a combination of antibodies, sometimes they give you a cocktail of antibodies and they're telling you finally what the patient is suffering from. And I remember one previous year paper question where they had told the patient has got IgG anti-HEV antibody positive, IgG anti-HAV antibody positive. The patient has got anti-HCV antibody positive, that is hepatitis C antibody. So they're given a combination of antibodies. Now the point to remember is acute hepatitis A has only acute phase. And after that, when you get IgG anti-hepatitis A antibody, that is anti-HAV antibody, it means the patient is recovered. That is not chronic. There's no such thing called chronic hepatitis A. Same way, anti-HEV antibody, if it is IgM, it indicates the patient has got acute hepatitis E. IgG anti-HEV if you get, that means generally the patient is recovered. Now you should understand that it is possible, you do have a very rare scenario where you can have chronic hepatitis E. It's been described in some African, zones, but it's very rare. In most of our subcontinent, Asian subcontinent, you don't generally get to see chronic hepatitis E. Meaning, if you get IgG anti-HEV and IgG anti-HAV, it simply means the patient is recovered. Or in case of hepatitis A, the patient could be vaccinated also. In that case also, you get anti-HAV, IgG positive. However, point is the mention of IgG anti-HAV and IgG anti-HEV suggests to us right now they are not suffering from hepatitis A. Right now they are not suffering from hepatitis E. Whatever it was, they have recovered from it. And the MCQ also mentioned anti-HCV was positive. That is hepatitis C antibody was present. So ultimately the answer was patient having chronic hepatitis C. So then when they give you a combination of antibodies, it's very important. This was a question that they had mentioned. They had given anti-HAV, IgG anti-HAV, IgG anti-HEV, and anti-HCV positive. The combination of these simply suggests to us that right now the patient is just having chronic hepatitis C, likely having chronic hepatitis C. As I told you, once you get IgG and IgG anti-HAV and IgG anti-HAV, since we don't, this is a 38-year-old man who's referred with a history of polydipsia and polyuria. This scenario of a patient having dilute urine being passed in excess in a 24-hour zone, that is polyuria, the differentials are very limited. There are only few things that can cause a patient to have dilute urine with polyuria. Those are either this is a case of a patient who's drinking excessive water, this is called primary polydipsia, or this is diabetes insipidus. Okay, there are only two main conditions to understand over here. Either it's primary polydipsia or this is diabetes insipidus. These are the two main conditions that will come with excessive water, dilute urine, and that urine is going to be very dilute. Urine osmolality is going to be low. So these are the two main conditions you should consider. Now, obviously, if the urine osmolality is high in a patient with polyuria, if the urine osmolality is coming high, that means if the urine osmolality is more than 300, here we're considering the urine osmolality to be less than 300. Okay, less than 300 milliosmoles per kg. If you find that the urine osmolality is more than 300 with polyuria, most likely it's some osmotic content that is pulling the water out in the urine. In that case, it is osmotic loss. If it is osmotic loss, some osmotic particle is pulling the water out in the urine. It is something like diabetes. It is something like, mannitol. It is basically some osmotic force must be there in the urine that is pulling the water, and that's why the polyuria also is there. So in generally those kind of scenarios, we're talking about either glucose is high in the urine or the patient is getting 3% saline, for example, and 3% sodium. If you're giving 3% saline, then excess sodium, whatever you're giving, will spill out in the urine, and the osmotic force of the urine is going to be high. The point is, when you get urine osmolality more than 300 with a polyuria, that means generally this patient has got osmotic loss. Okay, this osmotic loss that is occurring. Let's come back to the scenario where the patient is passing dilute urine and the patient has got polyuria. I told you one possibility is either the patient is forcibly drinking too much water. If patient is forcibly drinking too much water, then this is called primary polydipsia. Okay, polydipsia is drinking too much water and is referred to as primary polydipsia. So there are two main conditions. That means if somebody forcibly drinks too much water, obviously he'll pass, the body is not going to retain the water, he's going to throw it out in the urine. He's going to pass a lot of urine. So drink too much water, he's going to pass dilute urine. One scenario is that. The other scenario is the kidney is not concentrating, he's passing a lot of urine, he feels thirsty for that and he drinks water. Now what water he's drinking, this is referred to as secondary polydipsia. Okay, he's drinking water because he's losing in the urine. The primary problem is loss in the urine, in the kidney not able to concentrate. That's a patient with diabetes insipidus. A diabetes insipidus patient losing too much water in the urine, feels thirsty and drinks. That means this is not primary polydipsia, this is now secondary polydipsia. The point is, when you see a patient, you will see that he's got polyuria, and you'll notice he's drinking a lot of water. Every hour he's going on drinking. He's always keeping bottles of water close to him and he's constantly drinking water. Now your scenario is that both of the patients you see, whether they are primary polydipsia or it's a diabetes insipidus patient, both are consuming a lot of water, both are running to the restroom to pass urine. So they're passing a lot of urine, they're drinking too much water. That scenario is similar for both a diabetes insipidus patient and a primary polydipsia. Remember, primary polydipsia is also referred to as psychogenic polydipsia. Okay, generally it's a psychiatric problem. The patient is forcibly drinking too much water. So that's a compulsive drinker, also referred to as compulsive polydipsia or psychogenic polydipsia. So what's the other name for primary polydipsia? Because most of them are psychiatric causes, we consider them as psychogenic polydipsia. So now how do you differentiate between these conditions? One of the important concepts to understand is look at the sodium. Remember the sodium, when we talk about sodium concentration, is nothing but sodium to water ratio. So you know the normal sodium in the plasma is 135 to 145 milliequivalent per liter. This is the normal sodium. When somebody is forcibly drinking too much water, what you expect is that the body compartments are supposed to expand. I mean, there's excessive water toxication that is occurring. The patient is going to spill out that water in the form of urine later. But once he's drinking too much water, what you expect is the sodium should start getting dilute and you expect the sodium to start coming towards a lower limit of normal, that is close to 135. However, if the primary problem is a patient who's losing too much water because of kidney's inability to concentrate, that means it's diabetes insipidus. In a diabetes insipidus patient who's losing a lot of water, the water gets depleted and it will start concentrating the sodium. So expect the sodium to be on the upper limit of normal, that is 145. When you get a sodium in the MCQ coming close to 145, think about diabetes insipidus. If the sodium is coming close to 135, think about primary polydipsia as a likely possibility. So these are some clues that you might get in the MCQ to suggest you whether this is going towards diabetes insipidus or primary polydipsia. Bear in mind that when you have a scenario like diabetes insipidus, the patient is forcibly losing he's losing excessive water. If excessive water being lost in the urine, the sodium will start concentrating, the sodium will start going up. Never will you see a scenario of hyponatremia in a diabetes insipidus. Okay, unless you got two separate diseases occurring in the same patient. So typically diabetes insipidus patient is going to come with what? Sodium on the upper limits or lower limits? Upper limits. It could go above normal also, but it doesn't go below normal. That's the important idea. Same way, when a patient is forcibly drinking too much water, when he's forcibly adding more water to the compartment, then the sodium should get diluted, right? It should not be a state in which the sodium is getting concentrated. You drink water and sodium getting concentrated. That doesn't make sense. Are you understanding? He's drinking water. Sodium should be decreased, not increased. So these are some basic concepts to remember. Now in this question, we have got some values. They're giving you about the urine output. They're giving you the plasma sodium. I'll show you the question. You can take a look at it. And then I'll start discussing. Okay, try it out first. And then I'll tell you the answer. When you're looking at this question, obviously you're looking at a patient. They've mentioned the sodium. They're mentioning the plasma osmolarity. They're giving the glucose. Here they're giving millimoles. Either way, this is not a question of osmotic loss, because you can see the urine osmolarity initially at 0 is less than 300. Because this is less than 300, unlikely to be osmotic loss. So you can rule out diabetes as the answer over here. So it's not diabetes, right? If it was at baseline itself, the urine osmolarity would have been high, because in a diabetic patient, the glucose will be in the urine will be high. If there is glycuria, that is, if the patient is losing too much glucose in the urine, glycosuria, then urine osmolarity will tend to be on the higher side. It will go above 300. That's not the case here. So you can safely rule out diabetes from the option list. So you're left between the other options. It's diabetes insipidus or it's a psychogenic polydipsia. Now, when you approach these kind of questions, remember you need to look at everything. But then one of the things that they're giving is water deprivation test. The concept behind water deprivation test is, when a patient has got polyuria, What we do is we do the test known as water deprivation test, where we do not allow the patient to drink water. Remember, this has to be done inpatient because sometimes the plasma osmolarity can be significantly affected, causing the patient to be, developing complications. This has to be under observation, and it is inpatient. It's not an outpatient test. So water deprivation test, when you do it, then what we look at is at the end of 2 hours, what is the urine osmolality? Okay, what is the urine osmolality? When you do water deprivation, after 2 hours, urine osmolality, if it starts going above 600 milliosmoles, it's a clear indication for us that the problem was excessive water intake. Kidney's ability to concentrate urine is intact. Once you cut the water intake, because the kidney starts concentrating to maintain the body balance of water, it starts concentrating, then you will notice that at the end of 2 hours, the urine production will be around 600 milliosmoles per kg. This indicates to us that this patient simply has primary polydipsia. Okay, he was taking too much water, urine was dilute. You stop the water intake, the urine starts concentrating. Means concentrating ability of the kidney is intact. This is simply primary polydipsia. If you do water deprivation test at the end of 2 hours, if the urine osmolality is less than 300, it's less than 300, it indicates to us that there is a problem over here. This is suggestive that the kidney is not able to concentrate the urine properly. This likely is suggestive of a patient with diabetes insipidus. So keep it very easy. If you do water deprivation test, urine osmolality starts going above 600, it's easy, this is primary polydipsia. If it's less than 300, the patient has got diabetes insipidus. That means despite cutting off water intake, the patient is still passing dilute urine. He's not able to concentrate the urine. This is nothing but diabetes insipidus. The problem is, what do you do if it's between 300 to 600? When it's between 300 to 600, then you look at the other clues in MCQ to make a decision, because this could be mixed scenario, this could be partial scenario, partial diabetes insipidus. There are so many variations, but generally in my experience, I've seen partial diabetes insipidus kind of questions are generally not tested at the post MBBS level. Okay, these become more DM level questions, but at your level, they'll not ask you partial and all, so generally it's unlikely. However, the other clues are definitely going to help you to decide whether the answer is primary polydipsia or diabetes insipidus. Coming back to this question, now we are seeing over here that this is a patient who's got, okay, I think you can see the full question now. You have got a patient at 0, you can make out the sodium is already on the upper limits of normal. Remember, the normal sodium is 135. Notice the patient is 144. That means the upper limit of normal. Just the looking at the sodium itself in the MCQ, you will not have time in the exam to gloss over too much, to think too much about these kind of things. You saw the sodium. That's a clue. It's telling you that this is unlikely to be a patient who is primary polydipsia. It's unlikely to be primary polydipsia. Why? If the patient is forcibly drinking too much water, we expect the sodium to be more diluted. It should be on the lower limits of normal rather, not at the upper limits of normal. This is unlikely to be primary polydipsia. This urine osmolality at 0 hours is low dilute urine. You will not get dilute urine when you have osmotic loss. So this cannot be diabetes mellitus. As you can see, we are able to easily rule out diabetes. We are able to easily rule out psychogenic polydipsia. Once you have done that, then you're going to make a decision between now central and nephrogenic. The answer depends now on the desmopressin test. You give desmopressin and you notice that after you give desmopressin, this is before desmopressin and this after. Notice the huge difference. The moment you give desmopressin, the urine osmolality just climbed up. It indicates to us that the receptors in the kidney are working. What was a problem was simply lack of ADH. You gave ADH vasopressin. The kidneys got the receptor that is intact and it is able to recognize the ADH and concentrate the urine. This is the reason why desmopressin is able to make a difference. It indicates that receptor defect is not there. This is not a receptor problem. If it's not a receptor problem, then it's not nephrogenic diabetes insipidus. The answer here, that means, is clearly a central diabetes insipidus. So these kind of questions are generally very easy. The sodium will help you out. Look at the urine osmolality. This question, remember, after water deprivation, the urine osmolality, if it was less than 300, then we had no doubt the answer is clearly going towards diabetes insipidus. Here, the post water deprivation, they've given above 300, 346. But when you have this scenario where it is between 300 to 600, if it's, see, once you do water deprivation, urine osmolality is 600. Let's say in this, instead of the choice 346, if they had given 680, let's say, it was 200, you did water deprivation, after 2 hours, it became 680. It crossed 600. What's your answer now? This is nothing but primary polydipsia, also referred to as psychogenic polydipsia. This patient has got less than 300. Let's say it was 223 and it was 280 now. After water deprivation it is 280. It is less than 300. It means the water deprivation is not making any difference. Kidney not able to concentrate. It's still continuing to pass dilute urine despite water deprivation. It means this is diabetes insipidus. I told you when you get in between 300 to 600, look at the sodium. That's a major clue for us. The fact that the patient has got a sodium on the higher side indicates towards that this cannot go towards primary polydipsia. It is a case of diabetes insipidus. Some students are asking me, sir, if the sodium is high, can it be SIDH? Definitely not. SIDH comes with hyponatremia. Okay, SIDH comes with hyponatremia. Again, I'm telling you, SIDH does not come with polyuria. SIDH comes with hyponatremia. Sodium generally is going to be below 135. So if they had given SIDH in one of the choices, is one of the easiest choice to rule out in the answer. It cannot be possible that you get sodium so high in a SIDH patient. You cannot have polyuria in a SIDH patient. Remember those simple points. After water deprivation, when you got the urine osmolarity increasing and you notice that the patient's urine osmolarity is between 300 to 600, the sodium was helping you to make a decision that this patient has a high level of sodium. That means the sodium is in the upper limits. This is likely going towards the diagnosis of a patient having diabetes insipidus. This is not primary polydipsia. Once you got a patient with diabetes insipidus, the choice now is to tell whether it's central diabetes insipidus or nephrogenic. If you give desmopressin, the urine starts concentrating very nicely. This indicates the receptor is working, the central diabetes insipidus. You give desmopressin, the urine continues to be dilute. This is nothing but nephrogenic diabetes insipidus, right? This is the answer now. This is nothing but central diabetes insipidus. So this is how your approach should be in answering questions on polyuria. Again, I'm saying if you get a patient with polyuria, look at the urine osmolality. It's less than 300. There are two possibilities to consider, either diabetes insipidus or primary polydipsia. If the urine osmolality in a polyuria patient, the urine osmolality is more than 300, likely this osmotic loss. Think about diabetes, think about a patient with mannitol, think about exogenous patient is getting fluids like, too much of saline infusion. Those things can make the urine concentrated with polyuria. So that's how your approach should be in these kind of questions. Moving to the next question. Now, these kind of questions look very big. When you get large questions in the exam, if they give you clinical vignettes like this, then the trick is read the first sentence, read the last sentence, and look at the choices first. Then you can come back and start scanning through the question. It's very important that in these kind of large questions, if you are not able to, complete, actually you have to keep a clear target that you are doing somewhere around 70 questions an hour. And in the first hour, if you're doing 70 questions, second hour you're doing 70. That means you're touching around 140, and the remaining last hour you're able to finish all the questions. Out of I'm talking about 200 questions here. Then you're fairly in the you're doing okay. So you have to keep time in your perspective when you're doing these questions. Now this looks like a pretty big question, but before that, let's look at the choices. Now, when you look at the choices, they are giving you a brainstem tumor. So when you got a brainstem problem, you're expecting in the MCQ, if there is brainstem, then you're expecting cranial nerve problems. If you're looking at motor neuron disease, then you have to have typically motor neuron disease. In our exam, they expect ALS, amyotrophic lateral sclerosis. That's a typical MCQ that they'll give you. If they do that, then you'll see that the patient is going to generally have a mixed combination of UMN, LMN findings. If you get a mixed combination of UMN, LMN with normal sensory, no ocular muscles involved. The buzzwords that they'll tell you for MND, the 4 things you should just tick off through the question. In an MND patient, you should not have ocular involvement. You should not have any sensory findings. You should not have bowel bladder involvement. The patient should have motor only. And that motor typically, if they give you ALS, which is the most common type of MND, should have a combination of some UMN, some LMN findings. If these 4 points are fulfilled, the answer is going to go towards MND. When they give you multiple sclerosis, the age should be young. If they tell you less than 20, it's not MS. It's above 50, it's not multiple sclerosis. First is you're going to look at the age. What's the age over here? This is a 40-year-old. Possible it can be multiple sclerosis. Okay, less than 20, it's not MS. More than 50, it's not MS. That's one. First is age. Secondly, you're going to see a patient with multiple sclerosis having features of dissociation in space and time. Okay, dissociation in space and time means the patient is going to have more than one. That means at least 2 or more than 2 lesions will be there clinically. The patient is going to have imaging suggestive of multiple areas affected. Typically, optic neuritis, transverse myelitis, the thick myelinated tracts are typically involved. Sensory findings will generally dominate in the MCQ. So patient having fluctuating scenario, meaning the patient got a problem, he recovered 2 years back, they'll tell you in the MCQ, the patient had some blurring of vision, he recovered. 1 year prior to that, the patient had some weakness in the lower limbs and he recovered. That is basically the fluctuating relapsing remitting pattern of multiple sclerosis, which is a common type of MS. So those kind of features will be there. And multiple sclerosis, one more clue you're expecting is that they'll tell you the patient worsened on exposure to warm temperature. Okay, it is known as Oto's phenomena. On warm temperature, the conduction through non-myelinated nerves will become even worse. Okay, remember myelination, the conduction is 70 meters per second. Non-myelinated, the conduction can come close to around 2 to 5 meters per second. In a non-myelinated nerve, that is multiple sclerosis, demyelinating disease, central nervous system, demyelination. Already the speed is basically 2 to 5 millimeters per second. If you increase the temperature, the conduction in that will drop to below 1 meter per second, making the patient get significant symptoms. So the patient went out to the beach, he was in the hot sun, and his blurring became worse, or the patient's weakness in the lower limb became worse, something like that. They'll tell you that is nothing but Oto's phenomena, a very hallmark finding of multiple sclerosis. Plus, if they give you the CSF, they'll tell you oligoclonal bands are there in the CSF. So it's a patient should be between 20 and 50 years. It should be fluctuating symptoms. The patient fluctuating symptoms in the sense patient must have got prior episodes with recovery, typically optic neuritis, periventricular bands of sclerosis, brainstem involvement, cerebellar involvement, spinal cord involvement. These are the areas you're searching for in the MCQ. And sensory findings should be there. If those are there, the answer is multiple sclerosis. So before you start looking in the question itself, we know what to search for. When you got a patient with Syringomyelia, then Syrinx is central cord syndrome. It's a central problem in the spinal cord. It typically involves Syringomyelia, the cervical spinal cord. And what you're expecting is dissociative anesthesia, where the patient should have an expanding cavity in the center of the spinal cord affecting the patient's pain and temperature sensation. But the posterior column should be intact. That is joint position, vibration, fine touch should be intact. If you got a patient who's coming with burns in the fingers or the hands, generally asymmetric, one side the burns are more than the other side. If the patient has posterior column findings totally intact, that means joint position, vibration, fine touch. And this is because the syrinx as it expands, syrinx is nothing but cavity in the spinal cord. As it expands, the posterior cord is highly unlikely to be affected because the thick myelinated tracts posterior column, and posterior column being thick myelinated, they will not be affected, which means what is preserved in Syringomyelia, joint position, vibration, fine touch should not be affected. So a patient having cape-like distribution of having intact touch but loss of pinprick, loss of temperature sensation, this is suggestive of Syringomyelia. That's what you're looking for in the MCQ. Now, you will not have so much time to read in the exam. Looked at the choices, you know what you're expecting. Is there any sensory problem dominating the MCQ? You're looking for, on examination, preferably in neuro questions, you want to look at examination findings. Okay, in the neuro questions, you're looking at examination findings. You're showing reflexes are brisk, fine. The patient does not have any bladder, any visual, any bowel function abnormality. This is now suggesting to us this is unlikely to be a multiple sclerosis. This is unlikely to be a patient with Syringomyelia, because Syringomyelia, the predominant problem is burns in the hands and fingers. This is what they'll describe. This is nothing but dissociative anesthesia. That's not described here. This sticking up the things that we are looking for in motor neuron disease. The patient should not have eye problem, should not have sensory involvement. The patient should not have bowel bladder affected, should have motor, and that motor should be having some UMN, some LMN findings. If those things are fulfilled, the answer is motor neuron disease. So 1 or 2 sentences itself are telling you. Progressive weakness also tells you it's a degenerative condition. It's not something acute. Anyway, in this, they are not given anything acute. All are progressive conditions. Choices are all progressive only. So non-smoker finds she's dysarthric, so some cranial nerves are involved. Fasciculations of the tongue is a hallmark finding of motor neuron disease. Okay, fasciculation of the tongue, you ask the patient to hold the tongue on the lower lip. Okay, the patient should not protrude it out or take it in. Just keep the tongue on the lower lip, and you'll carefully, if you notice, you will see fasciculation. It means the 12th cranial nerve, LMN weakness is occurring in it. It is a highly suggestive feature of motor neuron disease seen in amyotrophic lateral sclerosis. So you do see some, UMN findings like reflexes are brisk. These are UMN findings. Presence of fasciculation is an LMN finding. Okay, fasciculations over deltoid triceps is an LMN finding. Lower limb shows increased tone, brisk reflexes, and weakness. There were fasciculations in both thighs, which is an element finding. So you're noticing some UMN, some element, and the important point, sensory system totally normal. A normal sensory system rules out Syringomyelia, multiple sclerosis. The answer is going strongly towards motor neuron disease. Okay, this is nothing but motor neuron disease. A brainstem tumor would have come predominantly UMN findings. You can't expect fasciculation in the thigh. It means the anterior horn cells that are supplying the thigh muscles must be affected. So that means lumbar area is involved, right? If you're talking brainstem, that is high up. Everything below should be UMN. When you got a brainstem involved, everything below should be UMN. That's not the case. You're seeing element findings in the lower limb. It means that these anterior horn cells are involved. So brainstem tumor is unlikely. Also brainstem tumor will come with sensory findings. That's not described over here. So all these can be eliminated. As I told you, these questions look big. They look overwhelming, but they're not that tricky. They're not that difficult if you know the major differentiating features. Again, this question looks very big and scary, but it's not. There are simple clues you can see in the question that will tell you the answer, so you can straightforward come down to conclusion. This is a 32-year-old singing teacher presented to emergency department with a 4-day history of worsening weakness affecting both legs. Now, I told you, read the first sentence in large questions, read the last sentence. Sensory examination was normal. The patient's plantar responses are mute and reflexes are absent. DTRs are absent. So I think you can see the full question now. So you can appreciate here that the patient has got a 4-day history of weakness affecting both legs. And then in the last sentence, you're noticing examination findings. Lower limb marked weakness was there, so it's LMN. Reduced tone is LMN. Okay, marked weakness throughout. Reduced tone, absent reflexes, so it's LMN. Plantars will not be working for LMN, and sensory examination was normal. So that's what you saw, first sentence, last sentence. They're giving you CSF findings, but they're giving you this kind of choices. Now look at these choices. Once they tell you that the patient has got Duchenne's muscular dystrophy in one of the choices, then this cannot be a 4-day history. Look at the history. This is a 4-day history. A 4-day history means this is not a degenerative, prolonged course of disease. If it was Duchenne's, they would have told you from past 6 months, from past 2 years, the patient noticed progressive falls and weakness in the muscles, difficulty getting up from chair, difficulty climbing stairs, skipping, hopping, jumping is affected. That's a description for Duchenne's muscular dystrophy. Also, Duchenne's typically involves children. Look at the age over here. This is a 32-year-old person. So if you get older person like this, typically by 12 years, the patient with Duchenne's is going to be bedridden. Okay, the wheelchair bound, right? This patient with Duchenne's by 12 years, that's one of the features of Duchenne's. By 12 years, the patient cannot walk independently and they'll be wheelchair bound. That's not the case. 32-year-old, 4-day history only, definitely it's not GBS. So just see how easy it is to rule out these kind of choices. In a patient with myasthenia gravis, there should be fluctuating weakness and typically DTRs are normal. Okay, deep tendon reflexes are not affected unless it's a severe myasthenia. Generally, in our exams, in MCQs at least, myasthenia gravis, DTRs will be normal. They will not ever give you CSF findings in a myasthenia patient. Nothing to do with the CSF. It's a nerve muscle junction problem. Amyotrophic lateral sclerosis is going to be a scenario where you got a mixed picture, some UMN findings, some LMN findings, sensory system should be normal. Do we have that over here? We don't have any UMN findings described. This patient seems to have just an LMN finding, and that too, a 4-day history again is highly unlikely to go towards amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, how they'll describe? From the past 7 months, the patient noticed progressive wasting in the hands and feet. The patient saw that they have difficulty in walking with some stiffness in their limbs. That's how they'll describe in MCQ. So months history, not days history. So months and months history is suggestive that this is going towards amyotrophic lateral sclerosis. 4-day weakness. A 4-day history of weakness should tell you this cannot be amyotrophic lateral sclerosis. What else are you noticing over here? Okay, this is a patient who's got marked difficulty in walking downstairs, rising out of the chair, complain of severe low back pain. This kind of radiculopathy is another feature suggestive of GBS. Denied any history of bowel bladder involvement. Again, GBS typically until advanced disease, you will not see bowel bladder involvement. Although autonomic manifestations occur in GBS, but they occur much later in diagnosis. In the last 24 hours, she has developed some facial weakness and she's unable to sing. So you know that bilateral facial nerve palsy, LMN facial nerve palsy is a classical finding of Guillain-Barré syndrome. She's unable to sing. She denied any sensory disturbance. That's what we expect in patients typically, although some paresthesias are known to occur initially in patients with GBS. She did mention she had cut a finger on a rose trellis whilst out gardening. Otherwise, she had felt well. She had a past medical history of psoriasis, fine. On examination, her BP was fine, pulse is 87, temperature is 36. So she does have some, BP on the higher side. But you do know autonomic dysfunction is a known feature for patients with GBS, and they can have fluctuating blood pressure, sometimes hypertension, sometimes BP on the lower side, possible. Heart rate, heart sounds, chest clear. Cranial examination, patient had bilateral facial nerve weakness. This is again a very important clue. Bilateral facial nerve weakness and ptosis, again a very important finding that you see in patients with GBS. Pupillary responses were intact. Rest of the cranial nerves are normal. Neck flexion and extension were intact. Upper limb reveal mild weakness of the shoulder abduction and adduction. So basically patient has got LMN findings. Lower limb involved, because the patient is mentioning history of lower limb, but on examination you're finding upper limbs also have some involvement. So you know this is how it will be in GBS. It will start in the lower limbs typically, although it can occur in all 4 limbs at the same time, but typically it will start in the lower limbs. It will involve upper limbs, it will involve the cranial nerves, and the patient ultimately will have respiratory problems. So that's why we talk about GBS as a typical acute ascending flaccid paralysis. So even the clue that they mentioned, the CSF findings, also will suggest to us that this is going towards GBS, because the very mention of the CSF table that they're talking about something about CSF tells you it cannot be amyotrophic lateral sclerosis. ALS, the CSF should be normal. Myasthenia, CSF should be normal. Duchenne's muscular dystrophy, CSF should be normal. Under stress in the exam, which of these conditions they'll talk about CSF? GBS is the only one. It should show albuminocytological dissociation. The protein should be increased, but the cell count should be normal. That's what you're searching for. The protein is high and the cell count is normal. The cell count is normal. So when the cell count is normal, CSF cell count is normal and protein is high, that's what we call albuminocytological dissociation. Sometimes, as you keep doing more questions, you'll realize that the very picture of a CSF being described in the MCQ should tell you the condition where CSF has relevance is only GBS. We look at the CSF for GBS, albuminocytological dissociation. We don't bother about the CSF in a muscular dystrophy or a myasthenia patient or a amyotrophic lateral sclerosis. So this is a 4-day history. Anyway, among all these conditions, the one condition which will have a short duration, a 4-day history of weakness, fits only with GBS over here. Typically, myasthenia also is a more chronic problem. Duchenne's is definitely going to be a year's problem. Amyotrophic lateral sclerosis is going to be months to years problem. So that all these, and MCQ not just discussing about ocular problem. Myasthenia typically starts with eye. Okay, the patient is going to have ptosis and diplopia. That will be the starting hallmark feature, and then other limbs also can be involved, but that will be fluctuating weakness. Sometimes weakness is there, sometimes not there. That is changing, fluctuating weakness. That's a hallmark feature of myasthenia. So this is not myasthenia. So I hope you understand these kind of questions look big, but don't get overburdened by this. It's not something to be worried about at all. The main clues you just focus on, and definitely start with looking at the first sentence, look at the last sentence, and then look at the findings. They're giving you some table of important points, or CSF examination findings, or complete blood count. The tables are very, very important. They give you any table, go through the table first, then look at the choices and start searching for the points in MCQ to concur with you. In a patient with GBS, we expect a rapid 3 to 4 day history of a patient starting with lower limb weakness, progressing upwards. It typically is going to be LMN, no UMN findings anywhere in the question. It might have cranial nerve involvement, especially bilateral facial nerve palsy is a known feature of GBS. And the CSF will show the CSF is going to show albuminocytological dissociation. If you get these kind of features, the answer is nothing but GBS, Guillain-Barré syndrome. So don't get overwhelmed by the large questions. They are actually going to make the job easier for you. The more one-liners you get, the more worried you should be, because either you know it or you don't. In a large question, there will be some or the other clue in the question that will help you to eliminate one of the options. Next, look at this question. This is a 52-year-old, so already we are seeing now older age patient. Brought to the office, look at the choices. They are all suggestive of dementias. And when looking at all dementias, mentally you know that if they're talking about gait as a predominant problem, you're going to go towards normal pressure hydrocephalus. Okay, the patient should have the triad. What's the triad for normal pressure hydrocephalus? Dementia, mild dementia, significant ataxia, gait abnormalities dominates the picture, and occurrence of urinary incontinence. Okay, occurrence of urinary incontinence. dementia, ataxia, and urinary incontinence. This triad is there. The answer is normal pressure hydrocephalus. So in that also, NPH, the dominating feature is going to be gait problem. The patient is going to have something called magnetic gait. So the occurrence of magnetic gait and ataxia is the highlight feature. It's a wide-based gait where the patient doesn't have a free lift of the feet. It looks like as if the feet is stuck to the ground, as a strong magnet is holding them down. That kind of picture is normal pressure hydrocephalus. So just scan through. It will not take much time for you. First of all, the age group on normal pressure hydrocephalus is much younger. This is 52 years, so it's unlikely. The patient seems to be having more cortical problems. Okay, aloof, distance himself, relatives, coldness. You're searching for gait, no ataxia, no incontinence. This is not NPH. Now you got three important choices. You got Alzheimer's, you got frontotemporal dementia, Lewy body. One important idea is typically Alzheimer's is going to be older age patients. So you're left between the three choices: Alzheimer's disease, frontotemporal dementia, and Lewy body dementia. One choice though easily you are able to eliminate. Remember that in the NEET exam, the way the negative marking is placed, if you can eliminate even one option, then you should try to attempt the question and you should not leave the question and come. If you don't have enough attempts, then expecting a good rank will be highly unlikely. So you should try to attempt this question regardless of whether you know the answer is A, B or C. This is a question that you need to attempt. Now let's dig into the finer points. In general, if you see the MCQ talking about somebody above 60 years, the possibility of Alzheimer's becomes more. Lewy body and Alzheimer both typically occur in very old patients and they are generally above 60 years. But between 40 to 60 years, if you're seeing in the MCQ, chances are it is frontotemporal dementia. 40 to 60, frontotemporal dementia. Above 60, chances are it is Alzheimer's and Lewy body. This is a soft marker. Age is not the only way you can make the diagnosis, because you can have familial Alzheimer's occurring in younger age. Just keep that in mind, however, that above 60, think more about Alzheimer, Lewy body, and below 60, think about frontotemporal dementia. When you got Lewy body dementia, you're searching for four main features. The patient should have fluctuating cognition, right? The patient should have something like a delirium. The patient is totally confused. He doesn't know where he is, what he's doing. That kind of confused state they'll describe in MCQ. That's hallmark of Lewy body dementia. You don't see delirium kind of picture in the other dementias. Okay, total confusion if you're getting, that is Lewy body. Parkinsonian features that they are mentioning, that is Lewy body. Visual hallucinations, hallmark finding, visual hallucinations, Lewy body. And REM sleep abnormality, where this is a very, very early finding. In fact, years before the patient develops dementia, the history will be there. The patient will tell that in the sleep, the patient is, dreaming, and what happens is in our dream, whatever movement we enact, like in a dream, we are awake. In our dream, we are awake. We are not aware that we are in sleep, right? We are doing, the brain is active. And if you record the EEG, actually it shows activity as if you are awake, isn't it? So this is a dream state that is occurring. In REM sleep, when the person's brain is functioning as if he is awake, the EEG is recording as it is awake, but the movement of the body will not occur in REM in normal people, because REM muscle tone is suppressed. In Lewy body, the REM muscle tone is not suppressed. So what he's enacting in the dream, the muscle will execute it. And if in his dream he's running, then he'll move his legs in the sleep. In his dream, if he's fighting off somebody, then he is going to be, thrashing and moving and kicking and hitting, most likely the spouse or the other people around him or sleeping next to him. That is all Lewy body. That scenario where in REM sleep, motor tone is not suppressed. And because of the lack of suppression of REM motor tone, whatever he's dreaming, he'll enact, he'll kick in his sleep. This is because in his dream also he's kicking somebody. That is all feature of nothing but Lewy body dementia. Okay, it's known as REM sleep abnormality. So what are the 4 points searching in MCQ? If it has to be Lewy body, they got to mention this in MCQ. What are the 4 points? The patient should have fluctuating cognition. That is something like a delirium-like picture must be there. Patient should have hypokinesia, rigidity, Parkinsonian features must be there. The patient should have visual hallucinations, REM sleep abnormality. If they're describing these features, this is Lewy body. A patient with Alzheimer will start with memory. It's always generally the rule. Alzheimer's starts with memory, and it has visuospatial problems. Memory problems, visuospatial problem, progress into language. These three areas are typically what is affected in Alzheimer's. Remember, visuospatial, very important clue in our MCQ, will not be described for frontotemporal. Let me repeat that. Visuospatial findings will not be described for frontotemporal dementia. Frontotemporal. Visuospatial circuits are occipitoparietal circuits. The disease must involve parietal lobe or occipital lobe. Frontotemporal, the dementia is restricted to these two lobes. It is restricted to frontal, it is restricted to temporal. You don't have parietal, you don't have occipital. That's the reason why you do not see visuospatial problems in frontotemporal. What is visuospatial? The patient's depth perception, the patient's ability to locate object in space, navigational problems. These things they will not describe for frontotemporal dementia. Navigational problems, depth perception, recognition of what object is where, all these things are affected in Alzheimer's and in Lewy body, but not in frontotemporal dementia. So visuospatial you do not get in frontotemporal dementia. They are seen in Alzheimer, they are seen in Lewy body dementia. Now I told you the broad concept. Let's look at what the MCQ is describing. If you want to choose Alzheimer, you got to search for memory as dominating picture. Memory, speech. Okay, remember the 4 A's for Alzheimer's? Amnesia is the most important. Apraxia is the patient is not able to button his shirt, not able to do stuff. Even though muscle strength is there, he cannot perform actions. That is apraxia. Amnesia, apraxia, aphasia, and the patient should have visual agnosia. What is visual agnosia? I told you visual spatial involvement, where the patient has got visual spatial problems. At the same time, they can have object agnosia. They are not able to understand what the object is because they have forgotten the remote, the TV, the pen. If you give it to them, they'll not know what the purpose of it is. So those are all features of Alzheimer's disease. So let's look. He reports a dramatic change in her husband's behavior, becomes aloof, distance himself from all relatives. That is nothing but apathy they're describing. Coldness towards his wife, that is nothing but apathy. So one thing we've got in this question is apathy dominating picture. He's got inappropriate sexual comments to strangers. This is a very important feature of frontotemporal dementia. Okay, hypersexuality. One of the things that you'll notice is there are patients with frontotemporal dementia. Frontal lobe is the major area where if there's a disease, the patient have behavioral problems. In frontotemporal dementia, you have two main variants. One is the speech variant, aphasic variant, and the other is behavioral variant of FTD. In the behavioral variant, the most common type of frontotemporal dementia is behavioral variant, where behavior features dominate the picture. Now, what are the main behavior features you're going to look for in MCQ? The patient will have apathy. The patient is going to have loss of empathy. The patient will have hypersexuality. He'll start making weird comments to strangers, sexual comments. The patient sometimes has got inappropriate comments. Sometimes, the MCQ will tell you that a patient was taken to the hospital. There he saw the receptionist before meeting the doctor. The receptionist was a little overweight and this fellow told it loudly to his wife, see how obese she is. Like those kind of inappropriate comments which are not, which are insensitive. Those are hallmark of frontotemporal dementia. So losing empathy, having apathy, becoming cold to relatives, the patient having psychiatric problems like hypersexuality, hyperorality. The patient can have some new compulsions, keep going to the bathroom every few minutes. Those are compulsions, obsessive compulsive kind of disorders. If they're all there, that is nothing but behavioral type of frontotemporal dementia. Remember, behavior is all connected with frontal lobe. They're describing behavioral problems here. Stop taking care of his personal hygiene. MMSE score is low, suggesting it is a dementia. Any MMSE score less than 24, they are talking about a dementia. So this is classical description of frontotemporal dementia. Did you notice anywhere in the question they're talking about visual hallucinations, REM sleep abnormality, fluctuating cognition? Those features not described, it's not Lewy body dementia. No Parkinsonian features, it's not Lewy body dementia, right? If you've got any of these features, no need to have all of them. But these features, if they are described in MCQ, this is suggestive of Lewy body. Okay, the core features we talk about Lewy body. Let me repeat, core features of Lewy body. The patient will have fluctuating cognition, REM sleep abnormality, visual hallucinations. They'll describe well visual hallucination, meaning well formed in the sense they don't have a confusing picture. They'll tell you, they describe the hallucination very nicely as if it's like a real image. That's kind of visual hallucination you will see in Lewy body dementia. These features, if they are there, is Lewy body. Alzheimer is going to be memory problem will dominate. They'll have some speech abnormality. They're going to have some, as the disease progresses. So obviously, Alzheimer, the sequence is temporal lobe, then it involves the parietal lobe, then it involves the frontal lobe, and last to involve is occipital lobe. That's the sequence, and that's the way all these lobes are involved. That's how the symptoms also occur in Alzheimer's disease. So this is definitely not Alzheimer's. So you're looking at frontotemporal dementia. This is known as behavioral variant of frontotemporal dementia. The clues towards FTD, the age is less, number one. Alzheimer, Lewy body generally should be above 60. Secondly, behavioral features have been described. That is hallmark of frontotemporal dementia. So look at those things to tell you the diagnosis. Moving to the next one. This is a scenario where they're giving you a pulmonary function test and asking you what's your diagnosis. The interpretation of pulmonary function test is very easy if you just know the basic concepts. We're looking at the FEV1, look at the FVC, look at the functional residual capacity, residual volume, and total lung capacity. Generally, in an exam, they'll not give you total lung capacity. They do, the MCQ becomes very easy. The very mention of total lung capacity decrease should tell you that this cannot be obstructive lung disease, because obstructive lung disease, air trapping will allow the lung to expand, and because the patient is not able to get all the air out, total lung capacity will be on the higher side. This will easily help you to eliminate chronic obstructive lung disease and typically asthma. One of the clues of asthma is, even though sometimes it may not have very high TLC, total lung capacity above 100% may not be there in asthma sometimes, because asthma is episodic. Okay, only when an asthmatic attack is there, then only you'll see. But generally asthma is easy because pre-bronchodilator, post-bronchodilator you're going to search. Whenever you have asthma, they'll always give you pre and post-bronchodilator, a dramatic improvement in bronchodilator response. Okay, if you're seeing more than a 12% improvement in a bronchodilator response, should suggest you that this is asthma. That's not described here. See, pre-bronchodilator 60%, post-bronchodilator, you give beta-2 agonist, that is not showing much difference. So fluctuating airway response, that means if you see a lot of improvement with bronchodilator, it's basically a hallmark finding of asthma. So this is not asthma. So just looking at total lung capacity itself, you can come to conclusion it's obstructive or restrictive. If total lung capacity is not there, then look at the FEV1 FEC ratio. In this, they have not given, they're given separately, but in many MCQs they'll give you the ratio itself, FEV1 FEC. If the ratio is less than 70%, then only the answer is obstructive. If the ratio is more than 70%, then you can say that this is restrictive. Okay, it is restrictive. So they've not given the ratio over here, but total lung capacity is a major clue for us. This cannot be obstructive lung disease. You got a total lung capacity low. Remember, the ranges are anything below 80 is significant for us. Anything above 80 can be normal. Okay, is total lung capacity below 75%? Yes. Below 80%? Yes, it is significant. It is decreased. Okay, in a normal person, some variation is possible. So we give cutoff of 20%. That means 80% to 120 is normal for us. If you're getting less than 80, it's definitely significant. For example, here you can see DLCO is 90%, right? So that means we are saying that this is normal. So you can actually write down DLCO is given normal over here. Okay, DLCO is normal. Functional residual capacity is normal. So once you are ruled out obstructive, it's not asthma because total lung capacity is decreased. It's not COPD. It's not asthma for two reasons. One, the TLC is low. Two, post-bronchodilator, no difference is there. This is not asthma. No air trapping is there. So in emphysema air trapping, hallmark finding, total lung capacity will be high. Not there. It's not COPD. It's not asthma. What are you left with now? Interstitial lung disease and myasthenia gravis. Easy now. Interstitial lung disease, the diffusion capacity of carbon dioxide will be low and it will be less than 80%. Here they're giving you a DLCO that is 90, meaning this cannot be interstitial lung disease. Okay, DLCO normal, it's not interstitial lung disease. And now restrictive lung disease, one clue is total lung capacity will be low. Total lung capacity will be decreased. The other clue is FEV1 FEC ratio will be more than 70%. But even though FEV1 FEC more than 70%, the patient's FVC will be less than 80%. If these findings are also given, this is also nothing but restrictive lung disease. This is restrictive lung disease. Once you have got restrictive lung disease, once you made up your mind that this is restrictive lung disease, as you can see here. So what are the points that will tell you that the patient has got restrictive lung in the pulmonary function test? Restrictive lung disease are FEV1, FEC ratio, more than 70 and FVC less than 80%. This is one point. Total lung capacity decrease. This is another point. These findings are there. This is nothing but restrictive lung disease. Now once you got restrictive lung disease can be further classified into parenchymal restrictive lung disease and extraparenchymal restrictive lung disease. Parenchymal restrictive lung disease, the interstitium is going to be thickened. This generally parenchyma means lung is involved. It's a fibrous thickened interstitium, and because of this reason, the DLCO is going to be low. Another important clue is parenchymal diseases, the residual volume and the functional residual capacity are all going to be low. Okay, residual volume, functional residual capacity, because thicker the interstitial zone, the more they recoil, and the thick alveoli will recoil more, and at the end of expiration they'll hold less air. That's why residual volume and functional residual capacity should be decreased. The problem with extraparenchymal is this is a chest muscle problem or chest disease. It's not a parenchymal problem, it's a chest pump problem. In this case, because the alveoli inside are normal, the DLCO is going to be normal. That's one clue. Secondly, if the patient has got extraparenchymal, remember when you say, what is residual volume? It's the volume that is remaining in the lung after forced expiration, which means you need force. When you're saying forced expiration, the patient has forced expiration. At the end of forced expiration, what air is remaining in the lung is called residual volume, correct? Now, in a patient who's got force, you got to have muscle power to get force. If the muscles are weak, then you can't get force. And if the force is not there, in a restrictive lung disease, you expect residual volume to be low. But if the residual volume is high, it means the muscles are weak. He is not able to generate the force to squeeze the air out. If he can't squeeze the air out, the air at the end of expiration will be remaining more. Here, look at the residual volume. Look at the residual volume. Residual volume is 120%. 120% means it is above, and residual volume 120% can't be possible in interstitial lung disease. So you can rule out interstitial lung disease because thick alveoli will squeeze more air out. Residual volume should be low. It's not low, it's high. So extraparenchymal restrictive, that means chest disease problem, the residual volume and the functional residual capacity might be high. Especially residual volume is the important clue for us. It will be increased. So extraparenchymal, can you give some examples? These are nothing but chest pump problems like chest muscle diseases. It can be a patient who has got myasthenia. It can be a patient who has got a disease where the nerve supply to the chest muscles are becoming affected, like a patient with GBS. It could be a scenario where the patient has got kyphoscoliosis, ankylosing spondylitis, whatever. These are all chest diseases. They are not parenchymal diseases. So that's how your approach should be in answering these kind of questions. So I hope you got it now. Pulmonary function test, very easy. If the FEV and FVC ratio is less than 70, the answer is easy. It's obstructive lung disease. If the FEV and FVC ratio is more than 70 and FVC is less than 80, the patient has got restrictive. Or in another way, if the total lung capacity is going up, that's obstructive lung disease. If the total lung capacity is coming down below 80%, it's a restrictive lung disease. This total lung capacity is reduced. Once the total lung capacity is reduced, we declared this patient has got restrictive. We ruled out choices are obstructive. It's not COPD, it's not asthma. Once you ruled out obstructive lung disease, you're left with two restrictive lung disease. One is parenchyma, one is extraparenchymal. The clues are a normal DLCO, a higher than normal residual volume. All suggest it's a chest muscle disease. It cannot be a interstitial lung disease. Interstitial lung disease, residual volume will be decreased. So this is your approach in answering these kind of questions. Let's look at the next one. A 26-year-old non-smoking woman presents for the second time for pneumothorax. So you got a young female coming with pneumothorax. She has no other past medical history. CT scan shows multiple cysts to the lung parenchyma. So when you talk about cystic diseases of the lung, there are two major cystic diseases of the lung that you should be aware of. The two major cystic diseases of the lung are lymphangioliomyomatosis and pulmonary Langerhans cell histiocytosis. These are the diseases, when they tell you cysts in the CT, or they give you a CT showing cysts in the lung, this is nothing but lymphangioliomyomatosis or pulmonary Langerhans cell histiocytosis. When you got these two, then the easy way to differentiate between these two is it a female or is it a male? Is the patient a smoker or not a smoker? Those are the clues that you're searching for actually. Between these two diseases, let's just look at the differentiating feature. Okay, let's look at the major differentiating feature between lymphangioliomyomatosis and pulmonary Langerhans cell histiocytosis. Pulmonary Langerhans cell histiocytosis. This is generally a female, usually in the reproductive age group. That means somewhere between 20 to 40 years. Usually the MCQ is going to be talking about third decade. So, but it could be anywhere between 20 to 40 years. Lymphangioliomyomatosis. Typically, this is a male patient, and typically they are older than 40 years. So that's the first clue you are searching for. Second important differentiating feature is both these conditions can have cysts in the CT. Both these conditions can have cyst rupturing causing spontaneous pneumothorax. The history wise, you will find sometimes there are a lot of similarities. Both can have, difficulty in breathing, dyspnea on exertion. The patients can have dry cough. The features sometimes look overlapping, and the history may not tell you much, but imaging will definitely show that cysts are present in both. But a major differentiating feature is this is strongly linked to smoking. Pulmonary Langerhans cell histiocytosis. You will not see smoking described for lymphangioliomyomatosis. Okay, lymphangioliomyomatosis, no smoking is described. Other clues are lymphangioliomyomatosis will have angiomyolipomas. These are additional clues, angiomyolipomas in the kidney, which they will not described in pulmonary Langerhans cell histiocytosis. The other clue is you can see lymphatic problems in lymphangiomyomatosis. Because of the lymphatic drainage issue, you can see patients having pleural effusion. You can see chylous ascites sometimes. Lymphedema can occur. Those kind of lymphatic problems are known to occur in lymphangioliomyomatosis. You will not see in patients with pulmonary Langerhans cell histiocytosis. Another important thing is if there is giving you image, let's say not giving any history, just image, then the cysts also will be helpful. Generally, the lymphangioliomyomatosis are thin-walled cysts, whereas these are thick-walled cysts. Okay, pulmonary Langerhans cell histiocytosis are thick-walled cysts. So to summarize once again, lymphangioliomyomatosis and Langerhans cell histiocytosis, these two things should come to your mind whenever they see cystic disease of the lung. And both of these conditions can come with pneumothorax. That's how typically the presentation is going to be in most of these MCQs. If you see young female who is not a smoker, who has pneumothorax, imaging might show some mass in the kidney. They might have pleural effusions. They might have chylous ascites. Those features are described. We are nothing but lymphangioliomyomatosis. Pulmonary Langerhans cell histiocytosis, hallmark is going to be smoking. Very strong relationship between smoking and Langerhans cell histiocytosis. So pulmonary Langerhans cell histiocytosis will be a very significant smoker. The patient is generally going to be a male. He's generally going to be more than 40 years. Look at all those clues to tell you that this is nothing but pulmonary Langerhans cell. And the cysts generally are thicker walled than what you see in lymphangioliomyomatosis. When you want to confirm the diagnosis, we've got a blood marker for lymphangioliomyomatosis, and that is known as VEGFD. Okay, vascular endothelial growth factor D, it is increased. It's an important manifestation, important marker of lymphangioliomyomatosis, which you will not see in Langerhans cell histiocytosis. Now, what's remaining is the treatment. The treatment for lymphangioliomyomatosis is going to be sirolimus. Okay, sirolimus. And you can even use rapamycin. The treatment in patients with Langerhans cell histiocytosis, most important treatment is smoking cessation. Okay, the mainstay of treatment is smoking cessation. Then after that, there is a role of using steroids. There is a role of using chemo. There is some benefit of using cladribine, cyclophosphamide. Okay, cladribine, cyclophosphamide, methotrexate, vinblastine, etoposide, all these drugs are used. I'm just listing one or two things, but these are all the treatments that are tried for pulmonary Langerhans cell histiocytosis. So remember these points to tell you whether the MCQ is going towards lymphangioliomyomatosis or pulmonary Langerhans cell. Whenever they say cystic disease of the lung, think about these two, and these are the points to focus on to tell whether it's lymphangioliomyomatosis or whether it is pulmonary Langerhans cell histiocytosis. Okay, moving to the next one. So this is a 30-year-old male presented with fatigue and pain abdomen. Remember, again, you're seeing such a big question, but whenever you see these kind of questions, remember the trick. To answer these questions, look at the first statement. 30-year patient came with fatigue and pain abdomen of 6 months duration. Right? That's the first point. Then last sentence. Differential count blast 1%. Okay, this looks like a hematology question. Blast 1% means you're telling this is not acute leukemia. Okay, this is not ALL, this is not CLL. ALL, AML will come with bone marrow failure features. This is not bone marrow failure features. Blasts are only 1%. So that's one point. Promyelocyte, myelocyte, metamyelocyte, band forms are classical description of immature myeloid series. Once you got this, eosinophilia is there, basophilia is there. These are all other supportive features of nothing but chronic myeloid leukemia. So when you see the first sentence, last sentence itself, you have a clue. Now look at the choices. They've given ALL, they've got AML, CML and CLL. When you're seeing ALL, AML in the MCQ, you've got to see a patient having bone marrow failure. One of the main features of bone marrow failure is the patient will have anemia, the patient will have thrombocytopenia, and the WBC count, whether it's high or low, they are not working properly, so the patient will come with infections. Okay, so bone marrow is failed. The main functions of bone marrow are not working. So will the MCQ definitely talk about anemia? Yeah. Will the patient have low platelet count and features of low platelet count like mucosal bleeding, petechiae? Those things will be there. Are they described here? No. Blast only 1%. Typically acute leukemia, blast will be more than 20%. You might say, what about some cases of AML where you have recurrent translocations? The blast can be less than 20%. Yeah, they can be less than 20%, but 1% is too less. Okay, 1% definitely goes against acute leukemia. Even in AML, where you have recurrent translocations, there also cutoff 20% is not fulfilled, means it need not be above 20%. Even below 20% is acute leukemia only, okay, with recurrent translocations. But in that also you'll see blasts are generally around 12, 13, 14, 18% like that. They're not going to be 1%. So 1% blast, acute leukemia out. Anemia is not there. Thrombocytopenia not there. Platelet count is high actually. What about hemoglobin? Anemia is there, but platelet count is not low. So this is definitely not going towards acute leukemia. This is not acute leukemia. Acute leukemia will come with bone marrow failure features. If it was acute leukemia, in a child, likely the answer is ALL. Elderly person, 65, 70 years, AML. So age is going to help you. They're not giving you age, look at the other features. The very description of a patient having neurological involvement, mediastinal lymphadenopathy are all clues going more towards lymphoid leukemias. If they talk about a patient having soft tissue chloromas, those features are more suggestive of acute myeloid leukemia, especially the M3, acute promyelocytic leukemia. They'll talk about DIC in the description in MCQ somewhere. A DIC description, where the patient D-dimer is high and the patient comes bleeding. D-dimer high bleeding, that is DIC. That is again going towards acute myeloid leukemia, that is M3. If in acute leukemia, I'm telling, if they give you the mention of CD markers suggestive of T cell or B cell markers, lymphoid markers, the T cell marker, they'll give you CD3. The B lymphocyte marker are 19, 20, 21, 22. Those are mature B cell, and immature B cell CD10. Those CD markers are mentioned. You're talking about ALL. If they're talking about myeloid series, 11 is leukocyte marker. 11 leukocyte marker. That's myeloid. Then you have CD marker of 45. That's all again myeloid. So myeloid markers are described in the MCQ. But the most important myeloid marker they'll tell you for AML is the patient having myeloperoxidase positivity. The patient is going to have non-specific esterase positivity. Patient can have OR rods, which are a very classical description for acute myeloid leukemia between M1 to M4. You will see OR rods. All those features to tell you the answer is acute myeloid leukemia. So again, what are the clues for acute myeloid leukemia? The patient is going to have CD marker suggestive of myeloid. Okay, 16, CD16, CD56, CD14, CD11. They're all nothing but myeloid markers. Look at those things. If you are seeing 117, very important marker, myeloid marker, okay, 117, very important myeloid marker, 117. If they mention it's acute myeloid leukemia. I'm just telling you acute, how to differentiate ALL and AML in the MCQ. One clue, age. Young, child, ALL. Older, AML. Don't go too much on age. They can sometimes confuse you with the age. Look at other features also. Look at the CD markers, CD3, ALL, T cell ALL, CD10, B cell ALL. Mature B cell markers, 1920 sometimes can be present. Those are all ALL markers. AML marker, myeloperoxidase, non-specific esterase, Sudan black B. These are all suggestive of AML markers. AML stains. The very mention of those stains will tell you this AML. Now there are some overlapping stains like PAS positivity can happen in ALL, AML, both. However, they mention TDT, they're talking about ALL. TDT, okay, terminal deoxytransferase is a very important marker of ALL. Okay, they mention it, they're talking about ALL typically. So these are all clues that you're looking at. Anyway, this is not acute leukemia. There's no bone marrow failure. The blasts are 1%. You're looking at definitely chronic leukemia. Once you decided it's chronic leukemia, because the blasts are only 1%, then in a CLL, the answer is easy. You only expect lymphocytosis, monoclonal lymphocytosis to dominate the picture. CLL, if at all, you know the mnemonic, right? The rise staging, if you know, then you can answer questions on CLL easily. Okay, CLL khake thukna hai. That's what we say, no? CLL spat is the mnemonic. This is a rise staging. So patient is going to have lymphocytosis first. The patient is going to have lymphadenopathy, splenomegaly, anemia, thrombocytopenia. And if you remember the staging also, no, you can understand more or less what's happening in this condition as well. So lymphocytosis, lymphadenopathy, splenomegaly, anemia, thrombocytopenia. There's a staging for eye, but then it also tells you what are the major features in patients with CLL. These are what you're expecting. They're not giving thrombocytopenia in this question. They're talking about anemia, but they're not talking about lymphocytosis. In fact, they're giving precursors of myeloid. Okay, look at the question. They give you myelocyte, metamyelocyte, promyelocyte. They're all precursor series for myeloid, right? Not lymphoid, not CLL, not lymphocyte. So this is definitely going to help you eliminate. The answer is not CLL. This is nothing but chronic myeloid leukemia. So whenever you want to answer chronic myeloid leukemia in MCQ, what are the clues you're looking for? The WBC count should be high. Precursors of a spectrum of all the cells until mature neutrophil. You're seeing all kinds of precursors that are there. Left shifted we talk about. Those are there. That is also a marker of CML. Presence of eosinophilia and basophilia is CML. Occurrence of splenomegaly. Is the splenomegaly described anywhere? Okay, presence of splenomegaly. Let's search through. Anemia is there. Patient has some lymphadenopathy. The patient has hepatosplenomegaly, right? So mention of splenomegaly is another important clue to suggest the patient has got chronic myeloid leukemia. So look at all these findings to tell you that it is going towards CML. Obviously, these are very easy choices. You can easily eliminate. You don't have bone marrow failure features. You got very low blast percentage, not acute leukemia. The patient does not have monoclonal lymphocytosis dominating the picture as a major feature. Then you might have some lymphadenopathy, some splenomegaly, anemia, thrombocytopenia in association. And that anemia could be a patient having warm autoimmune hemolytic anemia, Coombs positive hemolytic anemia, we say. Those are all clues to tell you it is CLL. So if you don't have that, then basically it will be easy to eliminate that option. This is nothing but chronic myeloid leukemia. So this is how your approach should be in these kind of choices. When they give you acute leukemias like this, I told you how to differentiate ALL from AML. Look at the stains, look at the age, look at the CD markers. That will tell you whether the answer is ALL or AML. Now moving towards 18-year-old, next question, 18-year-old boy coming with digital gangrene. Okay, so we have got a young boy who's coming with digital gangrene. Fourth finger for last 2 weeks. BP is 170/100. That means the patient has got hypertension. He's got digital gangrene. He's got hypertension. Okay, peripheral pulses are palpable. Looks like this is a vasculitis, right? Blood in urine examination unremarkable. Anti-nuclear antibodies to double standard and ANCA antibodies are negative. What's the most likely diagnosis? Anyway, all the choices are vasculitis, so you don't have to break your head. One connective tissue disease is there, SLE. So this is a male. This is not a female. Chances of it going towards SLE. First of all, you know in your mind, a boy is being described, not a female. This is highly unlikely to be, systemic lupus. You can generally consider it out. Anyway, if it is SLE, they would have told you ANA positivity, skin manifestation would have dominated. Those kind of things would have been the more likely. Arthritis. Those things would have dominated the picture for SLE. Now you're left between these. Now Takayasu is again below 40 years is possible. It is more of a vascular problem. But typically Takayasu will not come with small vessel. It's a medium to large vessel disease. And this is the reason why they'll not generally talk about digital gangrene. And the presence of hypertension, digital gangrene in a young boy is unlikely to go towards Takayasu. It's more likely to go towards polyarteritis nodosa. Agreed, both Takayasu, polyarteritis nodosa, you don't see antibodies. ANA or ANCA antibodies will not be there. Vaginous granulomatosis will definitely come with antibody mentioned in the MCQ. ANA, ANCA, C-ANCA antibodies is what they would have talked about. However, also the reason why it's not vaginal is a condition with a triad of 3 main features. ENT problems, sinusitis will be there. The patient is going to have lung problems, lower respiratory tract, and renal problems. So the patient having renal, lung, and ENT problem combination will tell you the answer is vaginous granulomatosis. That's not the description over here. So eliminating these, then this is not vaginous, this is not SLE. You're likely considering the possibility of Takayasu or polyarteritis nodosa. Now again, one important idea. Takayasu's the female to male ratio is 8:1. I'm not saying it's impossible to occur in a male. It's highly unlikely in an MCQ. In clinical practice, some male you might find a Takayasu, but in MCQ it should not be there. Okay, so because the ratio is so skewed, see, female to male ratio is 8:1 for Takayasu, highly unlikely. Takayasu, typically they would have talked about aortic arch dominating. That's the main feature that is there, Takayasu. Aortic arch is involved. Patient will have asymmetric pulses, Raynaud kind of picture in one of the limbs, claudication when they are walking, those kind of pictures would have dominated, the answer would have gone to Takayasu. This is not the way they're describing. This kind of looks like polyarteritis nodosa, which mainly comes with hypertension as a very important feature. The patient can have digital gangrene. The combination of findings that will tell you the patient has got polyarteritis nodosa. What are all the main features you're going to look for in polyarteritis nodosa? Okay, first of all, it's a medium-sized vessel vasculitis. And because of this, they'll highlight the issue that the lung is spared. Lung is never involved in patients with polyarteritis nodosa. They do have mononeuritis multiplex. But before that, what are the common findings you'll see in these patients? You'll see that they'll have arthralgia, arthritis. Musculoskeletal problems are very common. Musculoskeletal problems. Renal involvement is very common. In these patients, you will see them having hypertension and you will see increased creat. Remember the MCQ, there is no glomerulonephritis. This is because this is not going to involve small vessels. For glomerular capillaries to be involved, small vasculitis should be there. It's not there, so you will not see glomerulonephritis in polyarteritis nodosa. What else? Patients can have GI problems, in which typically they'll talk about bowel ischemia and abdominal pain, blood in the stools, nausea, vomiting. That description, nausea, vomiting, blood in the stools, all these things, they tell you this is nothing but bowel ischemia. That's possible. Occurrence of mononeuritis multiplex, important manifestation. Digital gangrene is a very important clue to suggest that is going towards polyarteritis nodosa. This is because digital gangrene in the other vasculitis is comparatively very rare. Okay, it is possible, but it's rare. But it's a very important manifestation they'll describe in patients with polyarteritis nodosa. It is linked with hepatitis B. It's associated with hepatitis B. And remember, there are no ANCA antibodies. Antibodies you will not see in patients with polyarteritis nodosa. And the treatment obviously is steroids. So these are all the things that if it is there, that will tell you. And one very important clue is you will see these patients having a rash. If this kind of a rash is given, livedo reticularis, very classical for polyarteritis nodosa. So see the mention of this kind of rash. If this there is highly suggestive of polyarteritis nodosa. Now I'm not saying livedo reticularis is enough to tell you pan, because livedo reticularis can occur in other conditions also, but it's an important clue for polyarteritis nodosa. So the combination of digital gangrene, the occurrence of a livedo reticularis rash, the involvement of organs like the kidney, where you see aneurysms, microaneurysms are forming, medium-sized vessels are involved, lung is not involved, no glomerulonephritis. Most patients will have hypertension because kidney involvement does occur. At least the branches of the renal arteries are involved. And that's why hypertension occurs commonly in patients with polyarteritis nodosa. The combination of these features should assist you and tell you that this is nothing but polyarteritis nodosa. So coming back to the question, it's definitely not Wegener, because Wegener would have been a combination of ENT problems, sinusitis mainly, lower respiratory tract. Patient will have lung involvement where cavities will be mentioned in the X-ray or CT, and kidney involvement. That combo is Wegener's. A patient having systemic lupus would have been more likely a female. First of all, they would have got ANA double-stranded antibodies positive. The patient would have come with skin manifestations, arthralgia, hematological problems, renal problems. A wide variety of combination of findings are possible in systemic lupus. Takayasu would have been again a female, 8:1 ratio, number one. Number two, it generally involves large vessel, some medium-sized vessels, but mainly large vessel. Because of this, Takayasu will come more with aortic arch features that will dominate the picture. And because of this, they'll talk about peripheral pulses not being equally palpable. Rather, they'll tell you about asymmetric pulses, claudication problem in one of the limbs, occurrence of TIAs, carotid insufficiency sometimes. Those kind of descriptions are all going towards Takayasu. That's not described here. The classical presentation of a male, of a hypertension, digital gangrene are all clues to suggest that this seems to be going more towards polyarteritis nodosa. Now you might say we don't have enough evidence in this to conclude it's pan. Yeah, we don't have, but we have enough points to tell you the others are not likely to be answered. That's all you need to know in an MCQ. Okay, moving to the next question. Which of the following seen in this ECG? So we've discussed the images at length in our vibe sessions, and I'm sure you are taking benefit from that. But this is a very easy ECG, and you can make out that this is a scenario where you're noticing after the P wave, the QRS is not occurring. Once you have a PQRS, a P wave is not followed by a QRS, then this is classically nothing but a type 2 heart block. Now, once you have got a type 2 heart block, among the choices, first thing you can eliminate is it's not a third degree heart block. One of the biggest clues to tell you the third degree heart block would have been the answer is the RR interval would have been equal, And this RR interval, if you check the RR interval, should have been exactly equal. Okay, because the escape rhythm that occurs in patients with complete heart block, once you have a complete AV node block, something below it will start firing. And when it starts firing, it fires very regularly. RR interval should be exactly equal in a complete heart block. It's not the case, then it's not complete heart block. Right? This is not complete heart block. Notice the RR interval is not equal. There's a missed beat in between. This cannot be complete heart block. Once you have decided that this is not complete heart block and it's not first degree heart block, there also RR interval should be exactly equal. This kind of variation in the RR interval should suggest you this is a type 2 block. Now, in a type 2 heart block, you got MOBITS 1 and MOBITS 2. The biggest difference between MOBITS 1 and MOBITS 2, in MOBITS 1, the patient should have a progressive prolongation of PR interval. And in MOBITS 2, the PR interval should be exactly equal. So I'll just zoom into this ECG and you can take a look. Okay, you can take a look at this ECG and you can see over here that the PR interval is what you want to focus on to decide whether it's a MOBITS 1 or MOBITS 2. Look at the PR interval. Over here, look at the PR interval. Here, look at this PR interval, look at this PR interval, this PR interval, and this PR interval. There's no change in it. And after the missed beat also, look at this PR interval, no change. So PR interval is not fluctuating. A progressive prolongation of PR interval will be a feature of MOBITS 1. That's not here. Here, the PR interval in each of the complexes, you can see the PR interval is equal. The fact that the PR interval is not changing should tell you the answer is MOBITS type 2 heart block. Okay, this is easy. This is nothing but MOBITS type 2 heart block. So for this question, what's the answer? There's nothing but MOBITS type 2 block. Okay, MOBITS type 2 block. Why did you rule out type 1 heart block? Simply type 1 heart block would have been prolonged PR interval. You're not seeing prolonged PR interval, and plus you're seeing mixed QRS. A mixed QRS will not occur in a first degree heart block. Why it's not a third degree heart block? In third degree heart block, the RR intervals would have been equal. There's no relationship between the P and the QRS. That features, if they are there, that is third degree heart block. That's not described. Why it's not MOBITS 1? It's not MOBITS 1 because you should have a progressive prolongation of PR. Then a P occurred and the QRS did not occur after that. That's MOBITS 1, also known as Vanke-Back phenomena. That is not seen here. The PR interval is fixed, so this is not MOBITS 1. The answer is nothing but MOBITS type 2 heart block. Finally, you're seeing the last question over here. This is a 55-year-old man who comes with recent syncopal episode, is admitted to the hospital in congestive heart failure. Okay, so you have a patient coming with syncope. And this is a patient who is having some heart failure features also. His BP is high, 160/100, pulse is 90. He's got a systolic ejection murmur, echo showing thickened ventricular septum. Now this alerting you, thick ventricular septum is highly suggestive of hypertrophic obstructive cardiomyopathy. One more major clue of HOCM is what is known as SAM. Okay, what is SAM? This patient is going to have systolic anterior motion of mitral valve. This is a very classical finding seen in patients with hypertrophic obstructive cardiomyopathy. Okay, systolic anterior motion of mitral valve. Which of the following is likely to be found in this patient? So in a patient with HOCM, what are you expecting with the murmurs? So dynamic auscultation is something that they'll ask you. You all know that in HOCM and mitral valve prolapse, these two conditions are unique in the sense, here less the blood, more the murmur. That's the main feature that you get in HOCM and mitral valve prolapse. Okay, less blood collected in the left ventricle, the louder the murmur is going to be. Generally in cardiology, we know more blood, more turbulence, because more blood passing through damaged area will trigger more turbulence and loud murmurs. That's not the case over here. Here less blood is louder murmur. So in a patient with HOCM, what happens to the murmur in Valsalva? Let's look at that first. In a Valsalva, because you are increasing the pressure in the thorax, the left ventricle fills less. When the ventricle fills less and it is pushing the blood out in the aorta, I told you less blood, louder murmur in HOCM and MVP. Here you're seeing decreased murmur, so this is definitely a wrong statement. One of the peculiarities of HOCM is you get a Bispherians pulse, not a pulsus parvus et tardus. So delayed carotid upstroke is a feature of valvular aortic stenosis. There's a subvalvular obstruction. Rather what you get here is a Bispherians pulse. So that's not delayed carotid upstroke. That is not HOCM. Increased murmur in squatting is wrong because in squatting, the left ventricle will collect more blood. Higher the blood, lesser the murmur. Less the blood, louder the murmur in the ventricle. At the start of systole, end diastolic volume we say. At the end, diastole is the time when blood collects in the ventricle. End of diastole, next step is systole. When it goes into systole, if it's got a lot of blood in the ventricle, it pushes the septum away and does not allow it to cause obstruction. In the left ventricle, if it collects less blood, septum already is coming in the way partially, creating obstruction, so murmur will be loud. So less blood, partial obstruction exists, murmur will be loud. more blood collected, septum pushed away, murmur will be softer. So increased murmur in squatting is wrong. Squatting will come with softer murmur. Standing will come with loud murmur. On squatting, the murmur will subside. That's a feature of HOCM. So the answer is clearly decreased murmur with hand grip. So in hand grip, what we're doing, we're increasing the pressure in the aorta. When we increase pressure in the aorta, then the gradient between left ventricle and aorta is decreased. Unless gradient is there, turbulence will not occur. So if you have an obstruction, before and after obstruction, the gradient is important. When you do hand grip, the pressure in the aorta beyond obstruction is increasing. So whenever you have, to give it in a very simple way, let's say you have this. So any obstruction that is occurring over here, this left ventricle cavity, this aorta, this subvalvular obstruction that is occurring, if you increase the pressure in the aorta, then the flow of blood will become slower. A slow moving blood cannot create turbulence. So that's the reason why whenever aortic pressure increases, like hand grip, like squatting, the murmur will decrease, and that's the correct choice. Decrease murmur with hand grip. Okay, so in patients with HOCM, there is decreased murmur with squatting and decreased murmur with hand grip. There is increased murmur with Valsalva, and any condition where the LV fills less blood, the murmur will start becoming louder. So standing, Valsalva, in all these conditions, the murmur becomes loud in HOCM. So those are all some basic points to remember. So I just give you some sample questions that they might ask in the exam. Most of the questions you will see are some things that you have already known about. It's not something that will surprise you, something new. Those things is not what you'll find. On the day of the exam, if you can think carefully, if you can logically eliminate the options, you should not have any problem in answering questions, at least from medicine. So this is it from my side. My best wishes to all of you. I hope all of you do well in the coming exam. Good luck.